15 or more years ago, a major study by the American Animal Hospital Association and Pfizer revealed poor levels of compliance in companion animal practice in the United States. The term was defined as the degree to which animal owners accepted and implemented the advice of their vet. The first report related to preventive medicine measures and revealed compliance levels ranging between 12 and 38%. Subsequent reports suggested that a significant proportion of the diagnostic, surgical and other procedures recommended by vets simply didn't happen. The other finding, highlighted in a paper by Tom Catanzaro, was that in using that term, the report appeared to cast the blame for poor compliance on clients, while the AHA study identified the vet as the primary culprit in the delivery of substandard care. During my own career, using the consulting room review tool in UK practices, we found non-compliance for a number of diagnostic and other procedures, including dentals, ranging from 40% to more than 70%. The result, of course, was that many thousands of pet animals simply don't receive the treatment they need. So what's to be done? In my volunteer role as a first responder with the ambulance service, I get plenty of opportunities to observe the teamwork between paramedics when they arrive as professionals to take over from the community responder, sometimes first on the scene for category 1 and 2 patients in their local community. Sometimes the case requires urgent medical attention and immediate transfer to hospital, but more frequently one member of the crew concentrates on completing and recording the standard clinical observations and all the other patient details, clinical history, past medication and so on, whilst the other spends most of the time assessing the situation, considering the options and communicating with the patient and other family members about their findings and recommendations and seeking their informed consent. So maybe the problem in veterinary practice, at least in the UK, where most primary care clinicians consult with the client without an additional staff member in the consulting room, is that there simply isn't sufficient talking time to seek and obtain the client's fully informed consent and to make the necessary arrangements. So if I were to own or manage a practice now, I would ensure that the lead clinician was supported by a second member of staff whose prime responsibility as an advocate for the client and patient would be to ensure that an appropriate treatment plan was agreed and arranged before the end of the consultation. Could such an arrangement work in your practice? I think it could. See you next time.